I had the opportunity to participate in a really lively Friday satellite symposium. And in particular, my session covered higher risk MDS and what's next, what's going to be available, and what else is out there. And in my session, I reviewed some of the drugs that are currently being assessed and are incredibly interesting, including the Venetoclax plus Azacitidine data. We discussed the ongoing trials that are being assessed, and this was also covered in Dr. Amr Zaidan's session with Sabatolimab and with Magrolimab. Sabatolimab is a TIM3 and Magrolimab is a CD47 macrophage inhibitor. We talked about those ongoing phase 3 studies as being incredibly interesting and pivotal for trying to change how we treat high-risk MDS. In particular, we discussed P53 MDS, which has been a real challenge for all of us clinically and in the clinical trial setting. I had reviewed the unfortunate negative study with APR-246, which was a P53 refolding agent that was tested in patients with P53 mutated disease. And unfortunately, the primary endpoint was not met. There are other P53 mutated active drugs, including Magrolimab, based on the early phase 1 data. So we were all discussing and looking forward to what might happen in the phase 3 study and how that might change our standard practice. We also reviewed some of the really encouraging data that came out of the BMT CTN study that was presented by Corey Cutler last year at ASH, that was then published in JCO this year, which strongly suggests that for high-risk MDS patients, frontline, that bone marrow transplantation with an allogeneic donor ought to be considered when donor is available, and that the data for survival looks much improved and for leukemia-free survival as well, including at the 3-year mark. And so there was a lot of discussion about timing of transplantation. Essentially, you go as soon as a donor is available, what to do before that happens. And that's where these phase 3 studies were really important. It's not just for older patients that are 75 and up that are not transplant eligible, but even for those that have active MDS that need disease control, cytoreduction, or disease modification prior to entering to transplant. The data historically has been mixed for the role of cytoreduction, or essentially treatment prior to transplantation. But as we have been discovering and really interrogating data of patients that go on to transplantation, we have discovered that there are definite subgroups of patients that just don't benefit from transplant, or they do poorly if there's leftover disease burden, or if they have a selective mutation present at the time of transplantation, or if they have persistent mutations after transplantation. And so I think it is really a responsibility for us to understand which populations might benefit from disease modification, understand the drugs that can do that, and understand which patients should get a little bit of therapy before transplantation to make them the best candidates to reduce the risk of relapse post-transplant. So we had really great discussions on that. We also reviewed very, very briefly the unfortunate negative data that came out of the Pevonedistat trial, which we were all looking forward to. That's a NET8 activating enzyme inhibitor that was added to azacitidine and compared to azacitidine alone in the phase 3 setting. That was called the PANTHER study. It was a really well-designed study with a primary endpoint of event-free survival. And there was a lot of enthusiasm going into the trial because the safety looks incredible for that combination. And the smaller scale phase 2 study that was presented by Dr. Sakharies last year looked very encouraging. But unfortunately, we were not able to see a benefit in the EFS or even and importantly, in the overall survival setting with top-line data that emerged from the trial. So unfortunately, we lost another competing drug out there that could have been another option for our patients. But at the end of the day, we really do need drugs that are able to change survival.